Welcome, everybody. Good afternoon. Thank you very much for joining us from wherever you are in the world. This webinar is the second of a discussion series on outbreak preparedness and response. This event is for all of those interested in infection prevention and control in low and middle income countries, to share their perspectives and discuss ways we can synergize investments in short-term outbreak responses towards longer-term quality improvement. My name is Emilio. I'm a member of the UK Public Health Rapid Support Team, and we're privileged to be joined today by four very special speakers and panelists. We have Professor Folashade Ogunshola, Dr. Stacey Mearns, Dr. Samuel Mangala, and Dr. Amy Elizabeth Barrera-Cantava. Let's just start now with a quick poll to get us thinking. I've got a question for you all now. In your opinion, what do you think cost more? The health expenditure for the whole population of Guinea, Sierra Leone and Liberia for the last 10 years, or the cost of the 2014-16 Ebola epidemic response? If you could just click on answer now, and we'll just discuss that for a second afterwards. Thank you. I'll just give you another 10 seconds to respond. Wonderful. Okay, let's just discuss the answer now. Could you show the responses, please? So the Ebola response, you can see where this is going. That's fantastic. So the Ebola response for that one outbreak was estimated by the OECD to have cost £53 billion. And that includes the knock-on economic and social costs from the epidemic. The entire health spending of those three countries for the last 10 years is very approximately about 13 billion. And so that I just estimated using publicly available data on per capita health spending and population. So whilst those sums are estimates, it does highlight the disparity between the costs of epidemic response and general health spending. So before moving on to our esteemed speakers, I just want to very briefly give you a bit of background about why we wanted to create this session. Before we start, just a quick definition. Infection prevention and control, we shorten to IPC throughout. And according to WHO, that is both the scientific approach and the practical solutions that are designed to prevent harm caused by healthcare acquired infections. So over the recent years, the role of IPC in outbreak response has become much higher profile, and significant investments have been made in improving the capacity to respond at local, national, regional and global levels. But thus far, there's been quite patchy translation of that experience and those skills and improvements from outbreak responses into the longer term and broader scale system strengthening in infection prevention and control. So in reality, we know that areas with strong baseline IPC structures and processes will be better placed to prevent and limit outbreaks using local resources, minimizing the need for intensive and potentially disruptive response activities. So in this conversation, we want to hear perspectives of those who've worked in IPC system strengthening, outbreak response, and also across a range of theatres. And we'll discuss, among other things, issues around funding, communication, accountability, and behavioural science. So on that note, I would like to hand over now to our first speaker to kick us off. Professor Folashade Ogunshola is a professor of clinical microbiology at the College of Medicine and University of Lagos, Nigeria. Her research interest and work has been centered mainly around the diagnosis and prevention of infectious diseases for AMR, and she's now been involved in IPC for over 20 years. She was a founder member of the Nigerian Society for Infection Control in 1998 and has assisted in setting up IPC programs in institutions throughout the country. She was chair of the Infection Control Committee and Antibiotic Prescribing committee of Lagos University Teaching Hospital, and is particularly interested in the application of infection control principles and AMR in under-resourced communities. She is currently serving on the Lagos State Government think tank for COVID-19 and the Africa Task Force for COVID-19. She's a member of the Global Infection Prevention and Control Network, board member of Nigerian Society of Infection Control, and chair of the Infection Control Africa Network. She will draw on this wealth of experience in her presentation for us today. Over to you, Professor Ogunchola.
Thank you very much, Emilio. I'll start sharing my slides now. My role today is to sort of set the stage for the other speakers that will be coming up after me. And what I'd like to talk about is the problem that we have on the African continent, which is what we call the verticalization of IPC. And what that means actually is that it has been fashioned around outbreaks. So you have silos of IPC. So I'm going to talk a little bit about where we started, how we got here, and why we're there, and just give a little bit around what we think or what we're trying to do to take us from there and to really center IPC in healthcare. Just for those who don't know, Nigeria is a huge country. We're about 200 million. This says 195, but people believe we're now 200 million. We have 37 states and 774 local governments. Our healthcare facilities are numerous. We have about 34,786 primary care facilities, 5,513 secondary facilities, which are general hospitals that do not do training per se, and tertiary institutions and specialist institutions, 164 facilities. Now, what has happened in the country is we say that healthcare is on the concurrent list, which means that these three levels are not necessarily always talking to each other. They're being managed by at different levels of government. So federal government takes care of the tertiary, secondary is taken care of by the state, and local governments take care of the primary healthcare centers. And this has implications sometimes for response. Just to remind us that infection prevention and control is not new. However, in terms of it being structured and so on, it's relatively new. But to remind us that the scientific study of hospital odonoscopy began in the 18th century. And in the 20th century was when it was applied to all areas. Prior to that, it tended to be focused on ONG and obstetrics and gynecology. And there were lots of, and the focus in many areas was in terms of the impact of staph and strep in the hospitals. So I did a little search, very cursory search for hospital infection in Africa. When I did that, I got nosocomial and Africa. So no hit in PubMed. Between 1970 and 1980, we had 7. There were 3 hits for Nigeria. There was from East Africa and so on. Then 1981 to 1990, we had 36 hits. Between 1991 to 2000, that was 10 years later, 103. 20% of these were linked to HIV, TB, Lassa fever, Ebola, and malaria. 65% were still linked to healthcare associated or hospital acquired endemic type infections. I just looked at some of the papers. Some of the first paper I saw on hospital services was in Dakar in 1966. In Nigeria, there was an epidemiological study of nosocomial infections in 1977. There was a study from South Africa that mentioned other studies, but this one was in the 1980s. So I looked further in Nigeria, and 1967 was the first talk of an outbreak of any organism in a hospital, and that was in, it was reported in 67, but this was done in 63. And then we have a list of them. But it was in 77 that anybody actually set out to study them. And this was by Dr. Daniels, who was also doing his, I think he was doing his PhD in the London School of, I think in the London School of Hygiene. So, tropical. Then infection control as a program. The mention of that started in the late 1980s. And a paper came out from South Africa in 1993 that spoke to talking about infection control and the quality of hospital programs. And it says the general level of healthcare in any country will dictate to a large extent the amount of attention it will pay to the control of nosocomial infections. And that does speak to quite a lot of our problems because as I go on, I'll explain further. So where are we now? We have all these silos. We have those who are trained in standard precautions and they're talking standard precautions. We have Lassa fever Ipc, we have HIV Ipc, TB Ipc, hand hygiene. We have WASH people, we have Ebola Ipc. Now we have AMR, where we started off in healthcare associated infections. Resistant organisms are what we're looking out for. In addition to the transmission, we recognize that healthcare associated infections were about resistant organisms as well, because that's where they generated a lot. Now we're talking about COVID-19 Ipc. So how did we get here? If you look at this arrow, which I sort of tried to make up to explain some of the things that have been going on in Ipc of nosocomial infection control study came out, Commission on Accreditation, and they made Ipc a program, a prerequisite for accreditation in hospitals in the UK and I mean in the Western world. However, around that time, we were just beginning in Nigeria to develop Ipc teams. And that was about 1980. The first paper that came out on HAIs was in 1977. By 1980, there were some Ipc teams in teaching hospitals in Nigeria. Then in 1986, HIV came. Now, let me say one of the major differences was the hospital programs were not well funded at all. Then HIV came and we started talking about universal precautions, and then there was a lot of money in Ipc, and suddenly everybody was into HIV universal precautions. And somehow in all that, the healthcare institutions that were doing Ipc were not a major part of this, because all these were focused on the community, on the local, on the primary health centers. It moved Ipc totally out of the hospitals when there was money into healthcare, I mean, public. Following that, in the 2000s, TB, swine fever, I mean, all the swine flu, et cetera, Ipc firmly became a public health response. However, there was still Ipc going on in the tertiary institutions, in the general hospitals, but they were not funded at all. Where it was funded was in the public health response, and that's where it became, should I say, attractive. Then in 2011, the NCDC, that's the Nigerian Center for Disease Control, was set up. In 2013, we developed a national Ipc policy and strategy, but it was very healthcare, I mean, was very epidemic response focused. Just going on, we kept working at advocacy for Ipc career path from the 2016. That was following the 2014 Ebola. And because of the 2014 Ebola, which are some of the dividends of these public health responses, funding came for us to start looking at training Ipc practitioners, which started in 2018. Also in 2018, the Ministry of Health said all hospitals should have an Ipc committee, although nothing much was done to ensure it was implemented. By 2021, where we're at now, we now have the NCDC has been positioned to take forward IPC in the country. And this also has been strengthened because of COVID. So IPC has, these epidemic responses or epidemics have had one good thing, is they've given us opportunities to move forward. But they also are all about he who pays the piper, because it's about the money comes in. As Emilio said at the beginning, it's a lot of money. It's a lot more than we spend on health anytime those resources, those epidemics, irrespective of what's going on. So let me just take something from Nigeria. There's very poor budgetary allocation for health on a good day. Less than 5% of the federal government budget was for healthcare in 2020, despite the fact that 15% is what is considered a minimum that should be allocated. There is a heavy reliance on donor funds, which means the government follows what the donors want. E.g., COVID-19 Nigeria, it was projected that we would need $330 million to control the pandemic. The government raised $560 million. 90% of these came from donors and from the private sector. Nothing of this was invested in institutionalizing IPC, or in fact, a lot of structures were built that were outside the normal hospital systems. And we have to remember that the epidemics are important because at any point in time, Africa is battling many epidemics, and we have weak health systems. Less than 30% of the countries in Africa have the workforce to deal with normal healthcare, talk less of the epidemics. We have less than 2.3 healthcare worker per 1,000 population, which is the WHO standard. So if you think about it, the focus on epidemics is really because it's a biosecurity issue. The possibility that these epidemics could expand out of the African continent. And as far back as 1979, there was a report from Walter R. Dowdell of the Center for Disease Control, and he said, some of these exotic viral diseases, public health problem in the United States. And it went on to describe them. Another paper that came out earlier recognized that these organisms also can be transported to other countries from people traveling from Africa. So the issue of epidemics and the money pumped into them is not absolutely altruistic. It's also about biosecurity for the rest of the world. And again, when a study was done in 2012, where will EIDs emerge? Again, you'll see Africa is there, as well as Southeast Asia. Again, for zoonoses and for vector-borne pathogens in particular, Africa is there. So it is also a biosecurity issue. And just to remind us all the goals of IPC programs, apart from, the safety of patients and healthcare workers and visitors, it's about preparing healthcare facilities for early detection and management of epidemics and contributes to the coordinated response. However, in siloficating IPC, as I like to say, and making it a public health response only, we actually go against what we are out for. Because the challenges of programmatic IPC is that it has weakened preparedness. Because IPC is seen as a public health response to epidemics and handled as vertical programs, governments wait for donors. And in between, no money is funded, healthcare is hardly funded. So many countries will not commit resources still to IPC. Therefore, IPC is not integrated into healthcare. There is very little institutional competence for IPC. The supply chains do not exist. There is inadequate infrastructure. The facility designs are not out to mitigate IPC. WASH structures are not there. inadequate personnel, not just in quantity, but also in quality. There's inappropriate or lack of technology, and there is very poor support by leadership for those who are struggling to make sure IPC continues. The other part of it, which is the problem, is that it has become everybody's business, so it's nobody's business. Many healthcare workers that have been trained in these silos believe that they're experts in IPC, and oftentimes they're the ones that are asked to take charge, but they really do not understand the science of IPC. They cannot drive the program within their facilities because essentially they've been trained to protect themselves. So we have few or no experts in IPC on the African continent. There are very few effective IPC programs in facilities. There's no system strengthening. The issue of safety climate are few, although we're beginning to see some hospitals taking charge on their own, more in the private sector, and then very few quality improvement services for clinical services. A study done just before the COVID-19 in Nigeria showed that 44% of our facilities are private, the rest are public, and 31.7% of them, in fact, 70-something% of our hospitals are private. The rest are public, and you can see them here. What we also found was that the facilities that had an IPC focal person or team, only 40% of them did. The facilities that had an IPC committee with responsibility and due authority, only 30% had. If those that had an IPC focal person or team with the work plan on IPC activities went down to 33.7%. So there may be teams, there may be committees, but they're not very functional. The country also had a national IPC strategy in 2013. Thanks to COVID and thanks to the NCDC being in charge now, there is a greater political awareness, and this political awareness that has risen is across the continent of Africa, and I'm hoping that many countries will seize this moment to make sure things are done. So right now, the policy is under review. So we recognize that for IPC to be effective, it has to be an ongoing activity. COVID-19 has given us a new opportunity to do this. And the state of IPC in Nigeria presently, which I think speaks to quite a number of African countries, is that IPC is still not being done properly, but there's a new wave and a new commitment, and the political will seems to be higher than we had in Ebola and the other epidemics that we have. And I think the reason for this is that COVID is stealthy and can affect anybody, anywhere. In Nigeria, because most facilities have no IPC focal person or IPC programs established, an Orange network has just been established, which is training IPC practitioners across the states of Nigeria. There's intensive advocacy going on with the Ministry of Health, with the NCDC, working together and reaching out to states and local governments to bridge the gap between the federal, the state, and the local government. In many facilities, there is no budget for IPC. I wish I could tell you that that has changed. It has not, but we're still hopeful, and advocacy continues. And I think that I can speak for most countries in Africa. There is very little data on IPC for decision-making. That's still there, but work is in progress. There are more people beginning to take interest in writing and putting their data out there. So I represent ICANN, and what we're doing is working to build IPC on the African continent. We're working in 54 countries. They're all the AU countries. We have coordinators for each region. We've been there for 13 years, and we have footprints in every African country. And we have 13 affiliate societies and trying to build till we have 54. We work in education, outbreak management, planting of associations, because those are support structures, and advocacy. We're pushing for national programs, facility programs. We're pushing for career paths for IPC practitioners, and we're doing training, not just for frontline healthcare workers, but also for IPC practitioners. But we don't stop there. We're also working on supervisory mentorship because we know the competencies matter. And we're also beginning to work to develop, so we've been doing some surveys, and we will be working harder to make sure that we get data on surveillance and HAIs. The issue of budgetary allocation for IPC is a tough one. So we continue to advocate for more funding for healthcare, because that will also make sure that there's funding for IPC. So at this point, I would want to thank all of you for listening and to say that my colleagues will take it from there. Thank you.
A huge thank you, Professor, for that really quite sort of deep and profound background and introduction to some of the issues around IPC. I think that's a really clear demonstration of the situation in many countries. So thank you so much for that. I'm sure that rings true for a lot of us on this call. Now we're going to move directly on to our next speaker. So we have with us next Dr. Stacey Meehan. Stacey's a UK trained medical and public health doctor with over 14 years working in the health sector, including 7 years in humanitarian emergencies. She's been involved in IPC programming across a number of emergency settings throughout her career, including 5 Ebola outbreaks. She's currently the senior technical advisor for emergency health at the International Rescue Committee. I will now hand over to Stacey to please give us your perspective. Thank you, and over.
Great, thank you, Amelia, for that introduction, and a warm welcome to everyone. So I wanted to share some reflections with you all, drawing on learning and experiences very much from an NGO perspective of implementing IPC projects, mainly as part of an outbreak response, but also with some experience implementing and working on IPC as part of a broader health system strengthening approach. I'm going to frame my remarks around these sort of 3 distinct but interconnected sort of aspects: reactive IPC, transitioning IPC post-outbreaks, and then also proactive IPC. So by reactive IPC, let me see if I can change the slide. Yeah, cool. So by reactive IPC, this is IPC that started and supported during emergency and specifically an outbreak where quick actions and results are absolutely essential. And I know this event is centered on moving beyond reactive IPC, but I think it's important that we start here. From my experience, I think there are still a lot of issues with getting this piece right. And if we don't get this right, then we don't have anything to integrate or transition or sustain. So I think it's important to ask ourselves, what is the most effective approach when we are doing reactive IPC? What gets us results, and what gets us results quickly? And I'm always struck at how frequently I see a one-off IPC training and putting some PPE in a health facility as the approach, which understandably and consistently doesn't work. We've learned a lot on this piece and reflected on this piece at the IRC over the years and across the different outbreaks and contexts in which we've worked. And this is culminated for us in the development of an IPC minimum package. And this package is really designed to provide guidance on how to operationalize global IPC standards in the context of outbreaks. It's underpinned by a multimodal approach, which is obviously very essential for IPC improvements. So before we can address how to integrate or sustain the investments that are made during outbreaks, I think we need to get the approach when reacting and responding to the outbreak right in the first place. As part of that, I think collaboration and coordination is key. The IPC demands during any outbreak are far greater than any one single organization or entity can meet. So multi-stakeholder collaboration with coordination and leadership from the Ministry of Health is absolutely crucial. I've seen again that the early standardization of approaches across partners is also very essential. One of the major challenges that I've certainly seen across Ebola outbreaks is lots and lots of actors involved in IPC, all with quite different approaches. And this can result in quite conflicting messages and vastly different levels of progress and support. So I think it's important that when we're reacting, when we're responding to an outbreak, that we're ensuring a standard approach across partners, a multimodal approach that we know that's going to be effective. I think we also need to and can, move beyond just thinking about a vertical disease-based approach at this juncture. You can't implement transmission-based precautions when there are no standard precautions. So instantly we have to look beyond, a single disease. We have to think about IPC at a health facility as a whole, and not just what we need for Ebola or what we need for COVID. And I think, having an early focus on standard precautions alongside transmission-based precautions, focusing throughout the health facility and not just at the entrance or the triage is really key. And last but not least on this, thinking about sustainability at this juncture. There's a lot of things that we can do in the approach we take at this stage that can help with sustainability. Be that, working with IPC focal persons, establishing IPC committees, thinking about permanent or semi-permanent infrastructure rather than temporary fixes. So, before we move beyond reactive approaches or look at integrating reactive with proactive approaches, I think we need to pause and ensure that we get the reactive piece right. Because when we do, I think every outbreak then brings a great opportunity to improve health systems if we prioritize transitioning the support and the significant investments that are often made during outbreaks. So when we think about transitioning IPC gains and investments, what exactly is needed for us to do this? What is needed to be able to capitalize on these gains and institutionalize IPC to broader system strengthening and quality improvement? I think firstly, we need to evolve. One of the biggest challenges, and Prof touched on this as well, when we transition support is often undoing the associations that have been made. This was a huge challenge in Sierra Leone, where at one point IPC became equated with Ebola. And there was a genuine concern that when Ebola was over, IPC would also be over. So we had a lot of work to do to evolve our support to un-Ebola IPC, ensuring that we were evolving approaches and support away from what was very Ebola focused and centric to much more comprehensive IPC. I think also, as part of that evolution, recognizing too that institutionalizing IPC isn't a one-time event, but needs to be a continuous process that needs to continue to evolve as context change and as capacities are established. Secondly, government leadership and ownership is absolutely essential, and we cannot institutionalize IPC within a health system without it. Again, going back to Sierra Leone, there was an enormous amount of political support for IPC. It featured very prominently in the presidential recovery plan. And this high-level political support resulted in the establishment of a national IPC unit within the Ministry of Health, the creation of an IPC workforce across the country, development of a national IPC policy, guidelines, and action plan. And all of these are really, really critical foundations for institutionalizing IPC. And then thirdly, in addition to political support, donor support and investment is also key. And this support needs to move beyond short-term 6-month project cycles and really be multi-year in nature. It also needs to be flexible to ensure that we can evolve support as needed, so that we can shift, we can adapt IPC approaches and support as capacities are established and strengthened. So what happens if we don't do this? What happens if we stop support when outbreaks finish? We had the rare opportunity recently during the most recent North Kivu Ebola outbreak to return to a few health facilities that we had supported as part of the prior 2018 North Kivu Ebola response, where we didn't have funds to continue IPC support. So when the outbreak finished, that support finished. And you can see on the screen that the blue bar represents IPC scores in November 2020. After this, support stops. And when we return in March 2021, so not much later, only a few months really, represented by the brown bar, you can see IPC scores pretty much, dropped at all facilities, and they've dropped quite quickly in a matter of a few months. You can also see from the scores that the blue bars, the progress that was being made, these are high IPC scores. So, I think the reality of instant drops, as well as the investments, they're big investments that's made when you have to do a reactive approach to transform IPC at facilities. It really highlights to me the important opportunity that is presented at the end of outbreaks to transition support and help ensure that IPC progress and improvements stay behind. But it's also not as simple as that. And I'm going to shift gears now back to Sierra Leone, where we did have the opportunity to transition IPC support as part of the post-Ebola recovery plan. And you can see graph 1 on the screen. So this is data from across 120 health facilities across 4 districts in Sierra Leone. And the graph shows the proportions of facilities that are compliant, partially compliant, and non-compliant with IPC standards. And so you can see from the graph that across the districts, very few health facilities are not compliant. The majority of facilities are compliant or partially compliant to standards. And this data is from August 2016. So this is 9 months post the end of the Ebola outbreak. So we see here, IPC standards and progress made during the outbreak starting to sustain beyond the outbreak, which is good. Moving over to graph 2, this is data from an IPC assessment completed as part of COVID preparedness, performed at the same facilities across the same four districts. Now, just a note of caution that the forms used in these assessments were not 100% the same, so we can't 100% compare like for like. But whilst we didn't have, exactly verbatim the same questions, the actual categories of what was being assessed in terms of compliance, looking at IPC organisation and management, WASH infrastructure, availability, supply availability practices, that was the same. So I think we are able to compare general trends. And essentially what you see in graph 2 is that 4 years later, we see a reversal in the trends that we did see, with the majority of facilities now not compliant across these districts. And for me, this is quite striking. This is an example of where big investments were made in IPC during an outbreak response, reactive IPC, and investments were also made to transition the support. But these gains haven't held 4 years later. And I think, no doubt transitioning IPC support from a reactive approach during an outbreak makes sense, especially when big investments are made. But I think, we have more questions than answers. And certainly I think we have a lot more learning to do about how to actually do this well, and fundamentally how to ensure that we can sustain gains well beyond the midterm and actually into the long term. So I think also, key to institutionalizing IPC is not reactive approaches after reactive approaches and trying to transition and sustain them, but to flip all of that around and for us to take a proactive approach to IPC. So regardless of outbreak, regardless of context, and this would clearly replace the need for such heavy reactive investments. So really moving away from IPC being neglected and only resourced and addressed when disaster strikes, to essentially looking at IPC as we should, which is a real central component of resilient health systems. For us, for us as an agency, the COVID pandemic has been quite interesting and quite helpful to put a spotlight on this and to really challenge thinking internally. So as part of our COVID preparedness efforts in the pandemic, we conducted an IPC assessment in over 1,000 health facilities across 22 humanitarian contexts where we were working. And the top graph on the screen shows global level results. The bottom level basically shows that the global level aggregate results, but broken down by region, just to give you a flavour of trends. Takeaway point from this assessment for us was that across all facilities assessed, only 13% met overall IPC targets and 70% did not meet those overall targets. What that meant for us as an agency was that around the world, 7 out of every 10 health facilities that we were supporting in some way failed to meet the 80% threshold for IPC. And when we dove further into this to understand why, it won't be a surprise to this audience to hear things like challenges with WASH infrastructure, breaks in supply chain, insufficient budget, etc. And, you know, for us as an agency, these results showcased a real disconnect internally, where on one side, you know, globally we're recognized as an agency for IPC support during outbreaks, yet in a non-outbreak setting across our humanitarian health programming, this is the reality of IPC where we work and support. And so I think this exercise for us was certainly the beginning of a wake-up call as an agency, and a recognition that we need to prioritize IPC across our health portfolios and health programs as a matter of routine and not just as a matter of emergency response. And we've so far taken some initial steps towards this more proactive approach to IPC. We've created a dedicated work stream and team within our health technical unit around IPC. We've developed very clear terms of reference to integrate IPC into the work of our program coordinators across sectors, so health and WASH, across our technical advisors, our program directors, really showing the roles that different stakeholders have to play in supporting and improving IPC. We've also developed an Ipc prioritization framework. So this includes, you know, key activities across critical IPC standards that are broken down by cost implication. So helping our teams really understand what can we do right now that will be impactful to improve IPC with little to no cost. What do we need to do that does require cost that has to be prioritized for funding, etc. And then also working with our health advisors to ensure the inclusion of IPC in our health program budgets, in our proposals, in our log frames, as a minimum standard and routine practice as we move forward, and not just something that we react and we do during an emergency. So I think there's still a long journey ahead of us, but I'm really pleased that we're at least starting to take steps in the right direction. To finish, in summary, I think there's a lot of work that we all need to do to ensure that IPC is no longer a neglected issue, and it can't just be seen as something that we do during outbreaks. It really needs to be seen as a fundamental foundation to any health programming. I think there's a huge need for more operational research to support learning and good practices around how we transition, around how we achieve results in different contexts. And I think, bottom line, we have to come at this from lots of different angles. We need to push for proactive approaches to IPC, ensuring that it's seen as a critical piece of quality. But we also need to ensure that when disaster strikes, we get the reactive approaches right. We think about sustainability from the outset, and that we have the commitment and resources to be able to capitalize those investments and transition support. And I will hand back to you, Emilio, and stop there.
That was really wonderful. Thank you so much, Stacey. Really fantastic, and a lot of food for thought there. And that was a wonderful presentation. We have another different perspective now to bring into the discussion. I'm going to introduce you to Dr. Samuel Mangala. Samuel is a medical doctor and he has significant expertise in leading both IPC and water sanitation and hygiene programs. He's also directed a number of large-scale health programs in vaccinations and maternal and infant services. He's led responses to many outbreaks of infectious diseases during his career, including HIV, cholera, measles, Ebola, and COVID now, for organizations including the Elizabeth Glaser Foundation, PATH, Oxfam, and the IFRC. He was president of the Democratic Republic of Congo's Ministry of Health IPC WASH Commission during the large-scale Ebola outbreak in Ituri, North and South Kivu. He's currently serving as head of the Division of Hygiene and IPC for the Ministry of Health in DRC. I'm very pleased now to hand you over to Samuel for the next presentation. Thank you. Over.
Merci beaucoup, Emilio.
Thank you very much, Emilio. So now we're going to talk among ourselves for a few minutes on the, I'm going to share the experience in the DRC and my experience for epidemics. This is my schedule for presentation. In relation to the epidemiological profile of the country, it's a big country with more than 20 diseases with epidemic potential. There's an ecosystem. The general population. And so 22% of the population has access to drinking water. And also, there are also natural disasters, especially volcanic eruptions, which also facilitates the spread of epidemics. There's also armed conflict and displacements of the population, which is increasing the threat from epidemics. We also have known a lot of epidemics before Ebola. And since 1976, up until the recent pandemic, but the biggest, which created a lot of victims, which lasted 2 years, and there were 34,000 some cases, 3,470 cases with 2,280 deaths. So in relation to the COVID, we are called upon. There are almost 40,000 cases already, with the case fatality ratio is about 2.3 per. Now, during the emergencies and the management of epidemics, the components in epidemic management are there. There is sterilization to be able to fight infections, and also there's waste disposal. The leading indicators in the emergencies, which helps us to measure the extent of the epidemic. We have the number of nosocomial infections recorded. We also have the number of contaminated providers, care providers. We have the number of the facilities with prevention levels equal to or greater than 80%, and the percentage of bodies, the dead bodies for which DHS was conducted. Now, for managing the epidemic in the Congo is not handled directly by the Ministry of Health. And so we have a committee to be able to manage the outbreak. And this is the organizational chart of the response on the national level. And so we have the other ministries, the other ministries get involved, that is defense, the interior, for example. And it's usually managed by the medical corps with its, they have the the techniques necessary to be able to manage the epidemic. I know on the interventional site itself, everything starts with the notification of cases, and depending on the various cases in the community. And so, the Surveillance Commission is in charge of that, of these cases. And these are cases which are declared in a hospital. And so we do a review of the case pathway with the Prevention and Surveillance Commission before coming to the hospital. And so we can share the differences to be able to show the chain of the contamination contacts. And once we do a mapping of the review of the case pathway, and to send them to the centers, to the facilities to be able to manage the outbreak. But above all, there is a team preparation by teams. And so there has to be a consultation between the epidemiologists and with the patients and their families and neighbors. And so for individual protection. And so we have these people dressed like astronauts who go into the community, and this has to be prepared beforehand by teams. And then after that, there's an intercommission consultation for prevention psychology in the RCCE. To be able to, then we're going to put in place teams to be able to carry out interventions in the community. These are patient organizations and others that take part in the process. And the implementation approaches, they are adapted according to the context. For example, when we managed the epidemics in North Kivu, there was the context of the resistance in the public health system, and also with the displaced population. And there are a lot of neighboring countries in the area at present. For example, with the pandemic of COVID, the DRSA's, the capital is in Kinshasa. It has the particularity of never having had to manage an epidemic. The majority of epidemics in the Congo occur in the east of the republic, except for the cholera outbreaks, which we're used to managing separately. And they've never known an epidemic in Kinshasa. And for that, the providers had never done preventive medicine before. And we also have the IPC belt approach. And we're going to have to be able to have the quality insurance as well. All the components have to be included. These are the 4 approaches which we have to blend together. So once on the intervention site, we have to assess the risk of contamination to others, the caregivers, the care providers, and we have to assess the facility's ICP WASH components. For example, we arrive at a hospital, we find that it is waste, which is just lying around. And the people don't have masks to be able to protect themselves from the ambient infections. And so we have to try and have to identify the internal problems in the hospital, that is the weaknesses. we have to develop improvement plan and provide technical support to the patients as closely as possible. And we're also going to monitor actions, that is isolation, prophylaxis, disinfection, etc. And we have to make sure that that is complied with. Has it been complied with? And then we have quality assurance that's required. So the pace of supervision during an epidemic, the frequency with which a site is monitored depends on the ICP level assessment score. So you have hospitals, generally these are hospitals which are private hospitals generally in rural areas, and they're not public. And so, in fact, they've got a good score. They have 80 to 100% equals once a week. And when the score is red, that means that there is 0 to 49% is the same as meant once per day. Now here, what I want to give you a few examples of for the present pandemic that is monitoring of some indicators in the DRC. So we have observed that in relation to the contamination of providers, health providers, the COVID, the DRC, there are 809 frontline staff as of June 22nd, 2021. That is an infection rate of frontline workers of 2.1% among all infected cases in the DRC. And the majority of providers work in the treatment centers for COVID. These are public and private hospitals. So these are treatment centers in the hospital with, as you see, with the percentage of the infection rate of frontline workers. And so these are the approaches to provider contamination to be able to manage the third wave. In the first wave, there were 9,844 positive cases and 501 positive frontline workers. That is a contamination rate of about 5.1%. And so that's with the first wave. And that is going to help us to control the number of contaminations the health providers, with the health providers. So the provider contaminations, what was the main cause for the contamination of frontline workers? The distribution of frontline workers who have undergone infection control in the first graph. Plus, you have contamination cases. And this was the first wave. The majority have not received infection control training, and these people were massively contaminated. And in relation to the PPEs and the training in PPEs, we've understood that the caregivers were used to working with the patient, with the diabetes patients, for example, that is people suffering from secondary diseases. And it's only by examining the patients that we're able to understand and explain them about COVID, to be able to implement the proper care with the understanding of and that's at the base of the contamination. That is not proper training in PPE and not proper training in infection control. Now, in relation to Ebola, provider and nosocomial contamination, this is an example of the second, the 10th epidemic. There were 3,444 number of cases, and there were 569 nosocomial infections, possible nosocomial infections, with 75 deaths out of 171 care providers. And we understood the situation. We had more contaminations. When we adapted our approaches to the epidemic, this reduced the number of contaminations and deaths. Donc, the indicators, the first problem was the PPE, which were insufficient. Because there was more contamination in the training periods, and there was no individual protection equipment, and so they didn't even have gloves. And for the even for the consultations. In the cases of hemorrhages, that's where we find the usefulness, and this can create problems for further contamination. It's also a problem with Ebola, because some people don't want to, there's a perfectly good will to wear a mask, but if you haven't got enough water, or if you haven't got enough of the other PPEs, it doesn't serve any purpose. So the major challenges in managing epidemics, there is always the problem of precarity. We also observed that there are a lot of incidents of armed conflict, civil unrest, community resistance, for example. There were 451 incidents, total incidents of all these things listed up here on the left-hand side. There's also precarity, which is not easy to overcome. And then support for the work at the site, and the access to water, and also parallel interventions, that is the more traditional operations. And so in conclusion, I would say the IPC intervention approaches has to be adapted to the context. It has to be participatory in involving service providers. It's flexible according to the epidemic's dynamics. And it is grounded in the health system, and it's a rational process. And these are the plans that we find in our zones and areas of intervention. Thank you very much for your attention.
Please, can I express a huge thank you to
Thank you
Samuel.
very much, Dr. Samuel.
Such an insightful and clear presentation from the perspective of Democratic Republic of Congo. Lots of achievements and challenges there to share, so really interesting. Our final speaker now is Dr. Amy Elizabeth Barrera-Canceda, but she is known as Ebeth. She received her Bachelor of Science and Masters in Public Health from Emory, where her studies focused on anthropology and global health, particularly infectious diseases. During the 2014-16 Ebola epidemic in West Africa, Ebeth was Director of Monitoring and Evaluation for Partners in Health, an international NGO in Sierra Leone, where she was responsible for collecting clinical data on patient outcomes and ensuring IPC measures were established within clinical sites to ensure both health worker and patient safety. After a decade working in the field, Ebeth returned to study her bachelor and then a PhD in nursing. Her passions are focusing on implementation strategies and behaviour change theories to improve infection prevention and control for health workers in Africa. I'm very pleased now to hand over to Ebeth for our final presentation. Over.
Hi, everyone. Thank you so much for allowing me to participate today. I'm just going to share my screen just now. All right, hopefully you can see that. So just to begin, I'll try to be a little bit quick because I know we're I'm very aware of time. But just to talk a little bit about, sort of to echo some of the statements and comments made from previous presenters today, really trying to transition and establish a culture of IPC in sub-Saharan Africa beyond sort of an acute emergency, sort of really developing an actual culture of IPC both at the healthcare facility level and at a larger sort of administrative policy level, so that we can actually effectively move into that proactive space that Dr. Mearns was talking about. I'm going to talk a little bit about today in terms of how you can, some creative ways you can try to maintain IPC momentum post-epidemic in sub-Saharan Africa. So there are like a few key messages for leveraging IPC momentum post-epidemic. And so I wanted to talk a little bit about sort of what are some of the critical IPC practices or needs that can be implemented during the acute emergency to support continued IPC efforts post-emergency. So similar to sort of what Dr. Mearns was talking about, sort of this really focusing on this transition period, and then how can we proactively continue this momentum after the epidemic by leveraging opportunities, during the acute emergency and that transition period. There are sort of 5 key takeaways based on my experience during EBD epidemics and other epidemics that I have sort of learned over the years in terms of things that I think can be very beneficial at making sure that that continued IPC momentum is leveraged after the epidemic. One is sort of innovative finance. One is stakeholder outcome agreement. Making sure that we are really sort of fostering IPC culture development among healthcare workers, really investing in prioritizing healthcare workers, and then of course prioritizing primary healthcare. So the first question I actually had here is, and feel free to please just type your response in the chat box, was which one of these statements is false? A, B, or C? And as I said, you can definitely just type your chat into the chat box, or your option into the chat box. Let me get rid of this. Any ideas? Does anyone have any ideas about which one of these is not correct? C. Okay, so you guys are experts. So absolutely. So it is estimated that the overall cost of the Ebola epidemic was around $53 billion US. The majority of that funding did come from the World Bank, Germany, the US, and the UK. And all funders who did support the implementation of IPC activities did not necessarily do so until the end of the epidemic or post-epidemic in terms of what may have been established in previous memorandums of understanding. So one of the things that I have learned sort of over the years, if you will, is that in order to really make sure that you are able to maintain IPC momentum, you have to sort of invest and get creative with innovative funding mechanisms during the epidemic that actually can be sustained after it. So what am I talking about? So for example, one of the things that I think is really interesting and controversial at the same time is this idea of leveraging financial resources during the actual acute emergency to ensure strengthened healthcare systems post-epidemic. I've had a lot of people say that it is not necessarily the best idea to worry about sort of the post sort of recovery period, if you will, of the epidemic while we're actually trying to address the acute emergency. I have a tendency to disagree. I think actually focusing on healthcare system strengthening initiatives, obviously particularly around infection prevention and control initiatives during the epidemic, is the ideal time to actually focus on sort of recovery period financing to strengthen these systems, because that's when you're actually going to have the resources in country. I don't think I have to tell anyone on this particular webinar that most of the time when the acute emergency is over, so do the resources that go with the partners or other stakeholders that were invested in the response. And so leveraging those finances during the emergency, but making sure that there's actually a proportion of financing that gets committed to the recovery period, I think is really important. One of the things that I have seen in other epidemics, not necessarily Ebola, but making sure that whatever sort of a financial agreement between partners or stakeholders and the ministries of health that is actually encouraged and undertaken during the actual acute emergency, seeing if a percentage of that funding could be dedicated towards the recovery period and earmarking those funding mechanisms for the recovery period is really, really important, which is not something that we typically do a lot in terms of the development space. And then, of course, trying to identify new ways of financial support during the epidemic, of course, but then also outside of sort of traditional funding mechanisms that we're very much aware of to make sure that there is sufficient support during the recovery period. So I know trying to really make sure that private sector individuals and individuals who typically are not involved in sort of the acute emergency space, making sure that we engage them as well is really, really important. Another key lesson is to ensure that all stakeholder interests have been assessed sort of during the epidemic so that the desired outcomes of interest because the desired outcomes for each of these will be different. So what do I mean by that? So we use a lot of, each stakeholder during an acute emergency and during a recovery period, they're going to be interested in very different outcomes. I think one of the critical things, and Dr. Mears also mentioned this and highlighted this as well, is making sure that during the emergency, any and all stakeholders that are actually involved in the actual outbreak, that a very good sense of what their outcomes of interest are is very, very important. As was mentioned, there was a variety of stakeholders during the EVD epidemic in West Africa, a lot of activities happening in silos and in parallel, and a lot of limited communication between partners a lot of the times. And so making sure that there's a clear understanding of what sort of are the desired outcomes of each particular stakeholder and making sure that we have very clear terminology around what we mean. So one of the things that I always take a little bit of a chuckle about is sort of this word sustainability. Sustainability as an implementation outcome measure really will mean something very different to each partner along the way. And in fact, in terms of the global health space, we actually don't have a very solid definition of sustainability because we all define it in very different ways. So just making sure that before you go into a recovery period and start talking about outcomes of interest in that recovery period, making sure that all stakeholders that are involved are in agreement and sort of what their outcomes of interest are. And then of course, one of the things that I'm very interested and passionate about is making sure that we're actually using behavior change theory so that we can leverage what individual stakeholders deem important with what they're also willing to do, including what they're willing to fund and sort of implementation strategies they're willing to invest in. Sort of the third key takeaway message is really sort of trying to initiate that culture of IPC among healthcare workers, and then of course sustain that after an acute emergency afterward. As was mentioned, we don't necessarily have a culture of IPC in sub-Saharan Africa, given that it is a relatively novel concept in a lot of our contexts. So making sure that we are sort of leveraging behavior change theory to understand sort of what are the inner contexts or some of the social norms, if you will. What are the healthcare worker conceptualizations and perceptions of IPC? What are some of these like socially identified constructs that really foster or influence IPC practice and behavior? And then of course, then using those social norms understandings to then implement multimodal strategies for IPC evidence-based practices at that healthcare facility level, which is so very important. So here's another question for you. I want to ask you now, before I go into my last two messages, which one of these statements is actually true? Okay, I see some A's, I see a B, just trying to see what else. I see C, so this one's a little bit, someone said none. This one's a little bit trickier, throwing a little bit of a curveball here. So the one that is actually true is B. B. Healthcare workers were often punished in various ways, if you will, if they did not want to work in healthcare facilities that they deemed and they perceived to be unsafe during the EVD epidemic. So sometimes healthcare facilities who were not compensated for many months at a time, healthcare workers were indeed supposed to receive hazard pay during this period, but unfortunately, many not only didn't receive their hazard pay, but as I had mentioned, were also uncompensated for months on end. Some of the punishments for not wanting to work in unsafe healthcare facilities related to IPC regulations were really, there were some healthcare workers that would be sent to rural clinics or rural areas to work as a form of sort of a punishment, if you will. Some would actually be retrenched. Some would then have any sort of additional incentives be withheld from them. And then there was a case of a healthcare worker actually being imprisoned for refusal to work. So the fourth key takeaway lesson that I think is really important is while you're trying to establish a culture of IPC, make sure that you're prioritizing healthcare worker safety and mechanisms to retain them in the healthcare profession during the epidemic. You can't expect healthcare workers are going to be exactly super excited about a recovery period and making sure that we have resilient healthcare systems post-epidemic to withstand a future epidemic if their experiences actually during the emergency are sort of perceived as being very deleterious or harmful or unsafe to either their job security or their physical safety. And again, this was something that came up a good bit during different epidemics that I've worked at. So making sure that no punitive damage measures are inflicted upon healthcare workers during the epidemic. So that way, if there are, during the recovery period, healthcare workers will have a more desired sense, if you will, to be able to invest in sort of IPC in healthcare facilities and sort of the further establishment of an IPC culture. And then of course, investing in healthcare workers and making sure that we're providing IPC career pathways for healthcare workers as well, and sort of the local levels. And then last but not least, wanting to make sure that something that is very important is making primary healthcare settings a priority during the epidemic, but most importantly in the recovery stage. The reason this is so very important, and again, I don't have to necessarily tell this group, but primary healthcare is generally the key entry point for most patients into a healthcare system. Generally, this is where you're going to start seeing your first cases of sort of patient zero and associated networks is at this particular level of the healthcare system. So investing in very strong administrative precautions at the primary healthcare level, both during the emergency, but especially during the recovery phase, to ensure that no HAIs and healthcare-acquired infections or any dangerous infectious pathogens have an opportunity to enter the healthcare facility are very important. And then of course, making sure that IPC measures are maintained, especially in essential services or through continuity of care mechanisms in the recovery period is also very important, because we know that when patients do not feel safe in a healthcare facility, mostly aligned with IPC, we've seen in the literature that when patients don't feel safe, and a lot of the problems of feeling safe are associated with IPC challenges at the healthcare facility, they will not come and utilize essential services. So this is also something that should be very much prioritized and flagged as that momentum is built during the epidemic, but definitely invested in much further in the recovery period or post-epidemic. I just would like to say thank you so very much, and I appreciate your time this afternoon, and I hope all of you and your families are staying safe and well. Thank you. Over to Emilio.
Thank you very much for that, Ebeth. Again, a very, very interesting insight, and I'm sure that sparked a lot of discussion and thoughts, again, from the participants on the call. We have now only a few minutes for discussion time. And I would like to bring all of our speakers together now. We also encourage you to ask a question of the speakers using the Q&A function, or just to share your experience or ideas relating to IPC. So if we can't answer all of your questions together in the panel, we will try and answer as many as we can in the Q&A function as well. So please just keep your eye on that for the next few minutes. I've got just one comment or question for all of the speakers, and it speaks to one of the questions that's been put in the Q&A about maintaining alertness when there isn't an outbreak, and the sort of psychological shift that's required for that. And I think that's been highlighted way beyond IPC. It's something that I've seen in climate change campaigners. They say that, you know, actually voter perception of a good disaster response to an environmental crisis is actually better than the preventative actions that would have stopped it happening in the first place. And I think that rings true for a lot of us in infection control as well. What do you think we can learn from other fields, or what do you think we can do to change that psychology around remaining, keeping the focus on something and valuing something when it's not the most immediate issue in front of people? And this is to all four speakers. Please jump in. We'll take in turns. I'd love to hear your viewpoints. Over.
I'm happy to start. So I think for me, I mean, it's really difficult, isn't it? And I reflect as well on my own, you know, clinical experience working in the UK, and how hard it is still with IPC in a health system in a heavily resourced country as well. And I think part of it is really focusing on what we mean by this proactive approach to IPC, which for me is getting to the point where IPC is fully integrated and a part of health systems and present right across the spectrum of healthcare service delivery. So it's not seen as something separate and over here that we do now and then when there's a disaster. It's seen as something that we do every day. And I think, you know, that the best place, I think, where we can start working on that psychology is actually pre-service training. You know, looking, and I know ICANN does a lot of work on this, but looking at, you know, nursing schools, midwifery schools, when we're training healthcare workers, trying to build that science so that people are understanding actually how this fits into everyday, you know, business and life as a healthcare professional, and how we do work. And I think that real, you know, pre-service training is a really important entry point to start to shift that psychology. Over.
Thank you, Prof. To you.
Thank you very much. I think, thank you for starting us off. I want to agree with you about the pre-service training. I think that's really important. But I think one of the major problems in sub-Saharan Africa is because there's really no structure for IPC. So even if you train people, as someone said, the best curriculum is in the activities. There's nothing going on. We don't have programs. So somewhere along the line, we've lost that. And I think, and then there's nobody who wakes up in the morning to say, IPC is what I do. And so we've been advocating for IPC practitioners, because if you have people for whom IPC is what they do, they will drive the field, because they will want to wake up in the morning and be validated and be useful. So beyond just the doing the work, everybody wants to be important. So they will drive IPC. Right now in Africa, there are very few places, I'm not sure where there is that career path. And what we found over the years is when you do train people well, you've done this, there's nothing for them to do. There's no structure in place. So I think we need to get back to the structures. I'm a particular fan of the WHO core components because I actually think it gets to the heart of the matter. The problem with IPC is we've left out the foundation and we're trying to build on top of nothing. The programs are important. You must have that program. That's one. And you must have the trained practitioners, not just all healthcare workers trained in point of care, IPC and prevention, but people who wake up and are thinking systems. So they're the ones that will drive the behavior change beyond the epidemic. And I think we need to get back to getting the programs in place and getting practitioners who will wake up and make that their duty. Thank you.
Thank you so much. Does anyone else want to come in on that? We're almost up to time. I think we've got 2 minutes left on the clock, and I'm sure there is a huge amount more we could discuss on so many of the issues falling out from this discussion today and all the things that we've learned and brought to the table. So I'm afraid, really sadly, with that very brief discussion, we're going to have to conclude the talk here and now. But what we have done is started an online discussion page that you're all free to access to continue this conversation. And we'll try and answer as many of the questions in the Q&A box that we weren't able to answer live today on the call. The link for that is now being shared in the chat box. You should see that. Another point is that we do hope to run future discussions in this series. So if you have suggestions for any future events, please do feel free to post them in the chat now, or also email the UK Public Health Rapid Support Team with your idea. That email will also be going into the chat as well. And finally, a huge thank you to everyone for joining us here today, for your questions and for your engagement in the chat. There's been a lot of discussion going on in the chat box, and it's been really great to see that from everyone. A massive thank you to all of our speakers for their very generous involvement and their deep insights into the different aspects of this issue. And also a huge thank you to the team who've been working behind the scenes to bring this event together and get it all functioning. So thank you very much to all of our technical team and of course our esteemed interpreters working to make sure that we can all learn from each other and get the most out of this opportunity. On that note, I'm afraid it's time for me to say goodbye. And thanks again to everyone on the call. And I'll just hand over now to the rest of our speakers to give a wave. And thank you again for taking part in this discussion event. And we look forward to hearing from you and continuing the discussion in the future. Thank you so much and goodbye.